Warm welcome to today's webinar on the HOPE campaign, Hodgkin Lymphoma Awareness, presented by ET Healthworld. I am Rashmi Kaur, Principal Correspondent at ET Healthworld, and I'll be your host for this insightful session. This webinar marks the third edition of our three-part series where expert doctors will address lymphoma, a critical and growing health concern. As the most common form of blood cancer, lymphoma affects the lymphatic system, an essential part of our immune defense. With the rising incidence of this disease in India, rising awareness has become more crucial than ever. Lymphoma is broadly characterized into two types, Hodgkin's and non-Hodgkin's, which are leading contributors to cancer-related deaths worldwide. Today, we are privileged to have renowned experts join us to share their insights on Hodgkin's lymphoma, including its diagnosis, treatment, and its vital importance of early detection. Now, let me introduce you to our esteemed panelists who bring a wealth of knowledge and experience to this discussion, starting with Dr. Chirag Shah, who is the Director of the Department of Hemato-Onco and Stem Cell Transplant Unit at Apollo Hospital, Ahmedabad. Dr. Alok Shetty is an Assistant Professor at Adult Hemato-Lymphoid Unit, Department of Medical Oncology at Tata Memorial Hospital, Mumbai. Dr. Jehan B. Dabar is a consultant medical oncologist and hemato-oncologist associated with Jaslok Hospital and Research Center, Mumbai, and Dr. Anshul Gupta, who is a director at Department of Hemato-Oncology and Bone Marrow Transplant at Medanta Hospital, Lucknow. Now let's start with the panel discussion. My first question is for Dr. Chirag. So, Dr. Chirag, could you start by explaining what is lymphoma so that our public is made aware of the first phases of how lymphoma actually starts?
Right. So, lymphoma is a type of blood cancer that affects the lymphocytes. So, we have many different cells in the body for the immune system, and one of the important cell is the lymphocytes. Now, unlike the other solid tumors, like say tumor of mouth or breast, the lymphocytes are all over the body through the blood and most of the organs. So the lymphomas can be in any place. And when like any other cancer, when the affected cells start multiplying out of control, that is when you form a cancer. Since this is a blood cancer or cells having all over the body, you can have multiple different nodules or lumps, and sometimes different organs are affected. So depending on what organ is affected and what type of lymphoma, the manifestations may be different. But very broadly, we can say that there are two main types, the Hodgkin lymphoma and the non-Hodgkin's lymphoma.
So, Dr. Jehan, how do we identify the signs and symptoms of Hodgkin lymphoma?
I would say most of the patients, initially would have practically no symptoms. Many patients turn up in the OPD to us when they just incidentally noticed a lump or a swelling in the neck or in the axilla. Just today afternoon, in fact, I had a young 30-year-old fellow who was a marathon runner. And just last weekend, he participated in some marathon in South Africa. And today morning, he said, while shaving, I saw this lump in my neck. So such a fit guy who had this lump in the neck, he's already been biopsied and proven to be an Hodgkin lymphoma. That's a separate thing. So that is just how shocking it is. So a young, fit individual also coming with a painless swelling can be something like a lymphoma. Otherwise, the classical symptoms that we see is persistent fever lasting for 3 to 4 weeks, or classically the night sweats, what we call. So when we ask the patient will tell us कि जब मैं रात को सोता हूँ मेरा पूरा टकिया गीला हो जाता है. So it's classical night sweats which we see. are also one of the presentations. Another very sad thing that we see is that the general practitioner or some local doctor would continuously treat them with antibiotics or presume it to be tuberculosis without investigating, and they would receive various other treatments, and then come to us when finally a diagnosis of lymphoma is made. So I really want to tell people that if you have a painless lump in your neck, in your axilla, or anywhere in your body, if you're losing weight, if you have persistent fever, despite taking medications from a local practitioner, there is no improvement, dig deeper, investigate deeper, meet a specialist. It will really save precious time.
Thank you, Dr. Jehan. So my next question is for Dr. Alok. Could you kindly elaborate on one of the subtypes of Hodgkin's lymphoma?
So Hodgkin lymphoma specifically, there are many types, subtypes. This is mainly based on the biopsy and various tests called immunohistochemistry that are done on the biopsy. Mainly speaking, from a treatment perspective, we have something called classical Hodgkin lymphoma, and the other being something technically called as NLPHL. So these are the two different subtypes largely with respect to treatment. Both have slightly different in terms of presentation and differences in terms of treatment and outcomes. Though for the general public, I would say what is important to know is that defining which subtype of Hodgkin lymphoma becomes important. So one needs to meet a specialist, have a good pathology, and who is diagnosing and working on the biopsy to tell us which subtype of Hodgkin it is, so that we can treat appropriately.
So Chirag, coming back to you, could you tell how do we actually diagnose Hodgkin's lymphoma for the general awareness?
Right. So the most important aspect to understand is that we need a proper biopsy. And many times the patients and sometimes even the family doctors want to make a diagnosis without biopsy. Patients are sometimes worried about biopsy, and they want to see if a PET scan can make a diagnosis or any other test, any blood test. So it is important to understand that no amount of scans or blood tests can make a diagnosis. They can all be presumptive, like possibility. So when somebody comes to us with a scan, and when the radiologist has mentioned that this is likely to be a lymphoma, and they want to get treatment based on that. So it is very important for people to understand that those are possibilities and sometimes things can change. Also, we know that there are total about 70 different types of lymphoma. And even among the Hodgkin lymphoma, there are multiple types. So the older way of biopsy was that you get the whole lymph node out. So if the lymph node is in the neck or the axilla, armpit, then you can get the whole lymph node out and get a very good histopathology. Nowadays, many times a good true cut biopsy or multiple true cut biopsies are frequently sufficient, but not always. So in this, the advantage is that this can be done as outpatient, since there are no stitches involved. There is no general anesthesia required, and under local anesthesia as outpatient, multiple core biopsies means using a special needle and getting biopsies from the lymph node is sufficient. Now, one of the other biopsies done with a needle is something known as fine needle aspiration. That is not sufficient. This is important again to remember, because we see that people get this type of biopsies and then they try to work with that occasionally. So FNAC or fine needle aspiration is not sufficient for diagnosis of lymphoma. Once the biopsy reaches to the pathologist, they would do the immunohistochemistry markers and then confirm. That is again an important point, that based on only morphology, means what you see under microscope, is not sufficient to make a diagnosis in the large majority of cases as of today, because there are so many subtypes. IHC is important to make that complete picture, and without that, based on microscopic alone, there may be misdiagnosis, and that treatment can change very widely. So patients sometimes have this question that why this additional expensive test. So IHC is important. Other than that, we kind of correlate the scan, generally a PET-CT scan, the clinical picture, the lymph node report, the biopsy report, and all that when they are matching, then we have no doubt about the diagnosis. Occasionally, lymphomas can have different varieties, and when there is a doubt, we ask for a second opinion. So somebody has come with a diagnosis, and if everything is not matching, then we may ask them to see a hematopathologist. So we send the biopsy to specialist pathologists who deal with blood cancer pathology. So these are some of the important points that we need to do in the planning of a proper diagnosis.
Important points mentioned. Thank you, Dr. Chirag. So coming back to you, Dr. Jehan, could you tell us how Hodgkin's lymphoma be prevented?
So, unfortunately, there's no way that we can truly prevent Hodgkin's lymphoma. We don't have any robust screening also that can help, like how in other malignancies, like for example, breast, cervical cancer, and other cancers, we have very good screening tests. We can detect the disease early. But so there's nothing really that we can do as such. I think being aware of the symptoms is important. As I said previously, acting at the right time is more important when we can detect the disease in the early stage. There are some risk factors, I would say, like probably when you have a known infection with Epstein-Barr virus, or if there's an immunocompromised state, these patients are slightly in a higher risk of developing Hodgkin's, but there's nothing more that we can do to prevent it altogether. But fortunately, it's very much treatable. So catching it early is the key to beating it.
So going on to the next question, what are the risk factors, Dr. Alok? What are the risk factors for Hodgkin's lymphoma, if you could elaborate?
Like Dr. Daba mentioned, there are largely not many risk factors in the sense that something which is easily identifiable and saying that this is the reason why Hodgkin lymphoma has happened. Interestingly, this is the most common question and the first question that patients tend to ask as to why have they been diagnosed with Hodgkin lymphoma, or why have they developed this disease, which is, I think, a very relevant question. But unfortunately, we do not have any single reason as to why Hodgkin lymphoma develops. So again, with respect to risk factors, like Dr. Daba again mentioned, very rarely in patients with Hodgkin lymphoma, things such as certain other conditions or disorders like primary immunodeficiency, which the patient has had long time, which can predispose them to certain infections, can also predispose to development of Hodgkin lymphoma. But again, this is a very rare setting. So in most patients, there are no identifiable risk factors as such for development of Hodgkin lymphoma. In more than 95% to 98% of patients, there are no definite risk factors. Though again, there is some categories, say males are more prone to Hodgkin lymphoma than women. And the age, usually this is a common in adolescent and young adults. That is the most common age group that we diagnose Hodgkin lymphoma, but that is not a risk factor per se, but that is where one commonly sees these patients.
Okay. Dr. Chirag, how do you decide to treat Hodgkin's lymphoma patients?
So there are three main factors here. one is the details about the disease itself, the details about the patient, and the patient preferences. So first is the disease details, that is exactly what type of the Hodgkin's lymphoma. Now, among the various subtypes, the main difference is whether this is NLPHL or the classical Hodgkin's lymphoma. So the nodular lymphocyte predominant Hodgkin's lymphoma, NLPHL, is one of the very uncommon type of Hodgkin, but it is important to identify that, and that is where we need a very good pathologist, because this subtype requires much less treatment, and many times they can be treated without chemotherapy, especially in the first stage. So if that part is identified properly by a good pathologist, then patient can be, patient can avoid chemotherapy. For the large majority, that about 95% of the Hodgkin's lymphoma, the treatment requires chemotherapy, and the number of chemotherapy cycles and the schedule and other details, what medicines are decided based on the type, the classical Hodgkin's lymphoma, then the stage of the Hodgkin's lymphoma. So generally stage 1 and 2 need comparatively lesser treatment, and stage 3 and 4 comparatively more treatment. And one very important part of determining treatment is the PET scan. So unlike many other cancers, PET scan here is a very important role. So we do a baseline, what we call PET CT scan, and after 2 cycles of chemotherapy. And in early stages, if the second PET scan is very good, then we can cut down the treatment a lot. Or if it is not very good as expected, then we can even increase the treatment to improve upon the results. Then comes the size of the disease. So if any of the lymph node area is very large, what we call bulky disease, then again the treatment plan has certain changes. Coming to the patient factors, we see the other diseases like heart problems, diabetes, blood pressure, the general fitness of the patient, any lung issues. So these are the, and of course, the age of the patient. So because some of the side effects are higher in older patients. And lastly, personal preferences. So sometimes we have in the early stages, we can have some patient choice also built into our decision making. So a lot of different things come into play in the decision making of Hodgkin's lymphoma treatment.
Dr. Alok, if you would also give a view on how is Hodgkin's lymphoma treated.
Yeah, like Dr. Shah has very nicely outlined, treatment depends on 3 major factors: the type, the biopsy or the type of Hodgkin lymphoma, the second being the stage, and the third being patient fitness. So based on the biopsy, whether it is NLPHL or the classical Hodgkin lymphoma, based on the staging is mainly based on PET scan, which is almost always needed in all Hodgkin lymphoma, whereas very rarely one can just do away with the CT scan. And the last being patient fitness. This is in terms of either blood tests through the organ functions mainly, which is liver functions and renal functions, along with other functions such as cardiac functions and the lung functions. So that is why routinely all patients of Hodgkin lymphoma undergo a lot of tests at baseline, which also includes 2D echo and ECG, which assesses the cardiac function, and a PFT DLCO, which assesses the lung functions. So based on all of this, one decides what is the treatment plan. Treatment plan mainly are two things. One is chemotherapy. Rarely nowadays we are also incorporating immunotherapy or targeted therapy in frontline. So that is one of the options. The second being how many cycles of this chemotherapy or immunotherapy needs to be given. And the last being radiotherapy, which is also an important aspect of treatment, more so in early stage and sometimes in advanced stage if there is a very bulky node or a node which is significantly significant in size, usually more than 7 centimeters or so.
Okay, so Dr. Jehan, how do patients or long-term survivors of HL adapt to the situation of having had a life-threatening disease and undergoing treatment?
Very pertinent question. There are two main, things that why this question is pertinent, because most of the bulk of our patients are adolescents and young adults, number one. So they're relatively, immature and still fresh. And the second good thing is that Hodgkin is potentially curable. So we have a lot of long-term survivors with us. So now, there is, of course, there are some implications, that we see. The three main things. First is the medical part of it, the medical aspects. Second, I would say the social aspect to it. And third is the psychological part of it. The medical part is something that we take care of. We keep the patients on follow-up for prolonged period of time because there are chances of developing second cancers that can be treatment related, or it is known to happen in Hodgkin lymphoma survivors. They can develop cardiac dysfunction even years together after treatment. Rarely even they could develop some lung problems happening, which could be treatment related, and other minor problems like endocrine, maybe thyroid disturbances, sterility, very, very rare, but it's known to happen. So these are the medical part of it, which we are always there for our patients. Coming to the social aspect, it is sometimes difficult to rehabilitate the patient. I'll give an example. We had a patient, an 18-year-old boy, but come to us. We treated him, by grace of God, doing excellently well. And he's like till the age of 24, 25, he followed up with us, and then he stopped coming. Few days back, he came to the OPD out of nowhere with his family. He must be around 27, 28 now. And now his problem is that he's due to get married with his long-term fiance, but there is some problem about the marriage because the girl's family found out that he had Hodgkin's, and now things are about to not work out. So he wanted us to talk to the girl's family and explain to them that this is a curable disease, and he was heartbroken at that point of time. So in we had to tackle this problem. So I spoke to his fiance. I told him everything is clear. If you want for satisfaction, we can even do a PET scan if required and check if everything is there. So all of these issues crop up in day-to-day life, which we have to deal with and face it. Second thing is, even many patients find it difficult to return back to work. Companies at times don't take them back when they know that they have a cancer and their job is at risk. So even rehabilitating at that front is important. And the third part, the psychological aspects. Very few patients, they have this constant fear that any minor complaint, the first thing that comes to it, oh, is it my lymphoma coming back? So it's a constant fear that they live in. So a lot of counseling, we require a good, it's a teamwork that I would say that helps to keep these patients in track on the day-to-day activities and day-to-day life.
Thank you, Dr. Jehan, for sharing your experience and how the patients actually have been going through a very tough time when they face lymphoma and the diagnosis and how it actually affects their entire life. So my next question is for Dr. Chirag. What are the patient's perceived communication barriers and facilitators at different stages after the diagnosis of lymphoma?
I think the point raised was very good earlier that these are young patients and their understanding about a critical illness is very different and they go through a very difficult time
Mhm.
because the whole life is ahead for them. And they have to cope with relationships, the peer, and the fertility. So, through this process, they go through various issues, and many times they want to ask a lot of questions about the issues that were raised. And at the same time, they are dealing with the issues at hand, which is the side effects or treatment related day-to-day questions. So, and some of the questions they are afraid to ask, or that does not come to them. For example, the fertility. And when patients are in the acute stage of illness, patient and the family members forget about the fertility part. But later on, when they are cured, then that comes to the mind. So we offer all these patients fertility related counseling and sperm preservation for men, and for women there are multiple options now also, that in case the treatment affects their fertility, then later on they have the ability to become a father or mother from the preserved sperm or the ovum. Luckily, I would say that the incidence of infertility is much smaller in these patients, in spite of the chemotherapy. But this is one important point. Then we also advise them to note down all the points so that when they come to us, they don't forget the questions that they always wanted to ask. And that helps them to ensure that they have kind of checked all the boxes in their mind and covered all the issues. Then they also meet the psychologist or the counselor, because many times, they also realize that main doctors don't have time to talk about their anxiety or fear related to the disease or its other aspects. Body image is an issue for young people, that hair loss and skin changes. So that also. Um, the scar from the biopsy, for example. So there are a lot of things that these young people want to ask, and having a psychologist in the team is very helpful. Even many of these patients share their problems or concerns with the junior doctors. So because the junior doctors or the nurses in the daycare unit where the chemotherapy is being given spend a lot more time with patient than the main consultants do. So these are all the different people in the team who are able to, take care of their concerns. And some of the points we proactively tell them, and some are brought out by these other healthcare providers or the psychologist.
Okay. Dr. Jehan, my next question is to you. What proportion of lymphoma survivors know about the risk of late effects that might be increased by the treatment period?
I think so. Usually, I make it very clear to all my patients before starting chemotherapy about the immediate as well as the long-term toxicities, the risk factors, the benefits of treatment, everything. I think it's a detailed discussion with all of us oncologists have with our patients before initiating therapy. But oncology has come a long way. So back in 1800, I think is somewhere when we started understanding what is Hodgkin's, the Reed-Steinberg cell, all of these, that understanding somewhere in the 1800s, they found out that patients came with masses in the neck, didn't know what it was back then. And that time all we had was X-rays. So when they used to do X-rays, they found that some of these nodes used to go away. That's when it started striking us that, probably radiation is something that will help, get rid of these nodes. So initially, back in the day, they used to do extensive radiation for treatment of Hodgkin's lymphoma, and inevitably, we radiate the entire chest or the abdomen, depending on the nodes. Inevitably, these patients had a lot of long-term toxicities, a lot of secondary cancers, as well as other problems. So that is something in the past now. Then the first chemotherapy regimen was something called MOP, a pretty toxic regimen which was developed, but had good results, better than radiation. Then we got wiser. There was another chemo protocol that came in, which was called BCOP. And we didn't know how many cycles of BCOP to give. So people used to give 8, 10, and they found that we had very good responses, but again, a lot of toxicity along with it. Now, finally, we have come to a much more effective and less toxic regimen called ABVD. So I think over the time has passed, we have so many newer treatments coming up. Our way of giving chemotherapy is more refined. Now with, we have brentuximab, which is a targeted therapy, we have immunotherapy, all of these in the front line, which are very safe. So, as time has gone by, we are wiser, we know how to, treat the disease better, and I'm sure in the coming years we'll know even more. But despite this, there are still some, long-term effects. As I said, one major concern is the disease coming back. Despite doing everything, there is a small chance of recurrence. Hence, keeping the patient under close follow-up is very important. And as I mentioned earlier, treatment-related side effects, albeit are very less now, but there's still always a concern, especially cardiomyopathy, that is heart problems, lung issues, and as Dr. Shah mentioned, fertility is also a concern at times.
Okay, and how do you, Dr. Alok, how do you plan the long-term monitoring of Hodgkin lymphoma patients?
Like all the other panelists have also highlighted, three major things while following these patients after treatment. First is to look for any symptoms or signs of relapse. The second being development of any other complications over a very long time, which could be things such as metabolic disorders like diabetes, dyslipidemia, which is increased cholesterol and its adverse effects. Or over a very long time, they can also develop cardiac dysfunction, secondary malignancies like breast cancer if they've received chest radiation. So this is the second aspect. The third being managing their comorbidities. That is, many of them already have diabetes, hypertension, or other illnesses when they're diagnosed with Hodgkin lymphoma. So this also needs to be monitored over a long time. Along with all of this, managing their, emotional and vocational issues that are there. So follow-up usually after the completion of treatment for the first 2 years, we do a physical examination every 3 to 4 months, along with a routine blood test, which could be a blood count, renal function, and liver function. So this is done for the first 2 years, every 3 to 4 months. After that, 6 monthly for say up to 5 years. And after that, annual checkup again with physical examination, blood tests, and sometimes an X-ray or an ultrasound. What is important to know is that PET scan is not routinely recommended after completion of treatment unless patient is having any symptoms and signs of treatment. Many times patients are very anxious and want to do an annual PET, annual scans, which is not recommended because over time studies has shown that doing such monitoring is not a necessary investigation or an intervention it will not really pick up a cancer earlier and improve outcomes as such. So just physical examination and some blood tests, and at the most an X-ray and an ultrasound, and not a PET is what needs to be done. This is how it's followed up. And specific tests, like for example, a breast examination or an echo in relevant patients, or a thyroid function test if they've received a neck radiation. So these are some specific tests for specific patients. So ideally, these needs to be followed up over a long period of time.
So as we conclude today's webinar, I would like to extend my heartfelt thanks to our panelists for their valuable time and expertise. Your insights have undoubtedly enriched our understanding of Hodgkin's lymphoma, covering crucial aspects such as awareness, early detection, and treatment options. We appreciate your commitment to advancing knowledge in this important area of healthcare. I would also like to thank our audience for joining the session, and we hope you found the discussion informative and empowering. Please share the knowledge to raise awareness about lymphoma in your communities. Thank you, everyone.